Good morning, ladies and gentlemen, dear colleagues. It's really a great honor and privilege to be here with you today and get the opportunity of opening this morning session of the last day of this advanced module. I hope you had a nice time last evening at the castle, and the dinner was fine. And I really do hope that you had some time to see our beautiful city, Ljubljana, and you enjoyed its beauties and food and wines and so on. I'm sure you get acquainted with that. We have quite a busy schedule today morning on the last day of this module, and so far as I could see from the program, you were acquainted and discussing mostly of the bacterial infections and the problems around them. However, bacteria, as you know, are not the only microbes in the world. So it's high time that we start to proceed with other microbes, and today this first session is dedicated to viruses and a little bit also to the fungal infections. I'd just like to give a word to my co-chair.
Okay, I'll be short. Good morning, everybody. So we'll start with lecture antiviral treatment hepatitis.
So I took the privilege of chairing the session, and I changed the order of the presentations. I'll start with the viruses that are most common and that all of you are getting acquainted with them. So herpes viruses, influenza virus, and then I proceed to hepatitis viruses, and then Professor Tomažić will, do you hear me? Everybody, I have a strong voice, so no problem. Okay, and then Professor Tomažić will proceed with HIV/AIDS. As you know, the extent of the pipeline of antimicrobials is very diverse. There are many antimicrobials for bacterial infections. As you can see, obelix, asterisk, there are much less with antiviral infection, and as for fungal infection, the number is even smaller. And now let's first face with this 27-year-old female, my patient. She's unmarried, she has stable relationship, and she has genital herpes 10 times per year. Can you imagine? The average duration of each outbreak is 5.6 days. However, of course, she's a woman. She has a menstrual period twice a year. It lasts for approximately 5 days. So just ask ourselves, what's her sport activities? What's her intimate relationship? She's worrying about transmission to her partner, transmission to her possible future newborn. So no wonder she's so sadly staring at these waves, gray waves, and no wonder she's dealing only with her computer and nothing else. So the question is, can we help her? Do we have any help? I noticed that there is a very diverse level of education among you, or level of your professional activities. So allow me to start at the baseline, just to say a few points on antiviral treatment. So as you know, the viral infections, so the clinical course of viral infections definitely depends on the role play between the virus pathogenicity and patient immunity. As you know, the viral infections can be acute, chronic. However, they can also be latent, and they can actually reactivate. And usually for viral infection, we say, well, no treatment, it's symptomatic, of course. It's a general opinion among people. However, we do have, as you know, some antivirals, and their usage has 3 levels. They can be used as a treatment, which means we do treat the clinically overt disease with signs and symptoms and laboratory baseline. Then they can be used as preemptive treatment, which means that there's no disease. However, we do try to prevent the disease because there is an increased replication of latent viruses. We can see the viremia. And third, it can be used as a suppressive treatment. So no disease, no virus, so far no viremia. However, we are expecting the outbreak of the virus, so we prevent that reactivation. As you know, the viruses are intracellular microbes, which means that they replicate there and that they use the viral, the cell particles, the cell enzymes, macromolecules, and their organelles. So it's really difficult to make a technology to produce new antiviral drugs because these drugs speaking very simplified, have to discriminate between the host functions and the viral functions. So actually, antivirals are no magic bullet. Generally speaking, we are facing with main problems such as toxicity, efficacy, and resistance. Not only resistance in antibacterial treatment, but we're already facing resistance with antiviral treatment. So what are the drugs used for treatment of viral infection? They can be directly antivirals, which prevent the viral replication intracellularly, such as like nucleotide analogs, or inhibitors of some cell enzymes, such as protease inhibitors, polymerase, integrase, and so on. However, on the other side, we can use also immunomodulators in order to enhance or change the host immune response, such as interferons or such as like biological treatment, as you know. So in 2019, we have more than 50 antivirals. However, the majority is used or was made for treatment of HIV/AIDS. But very importantly, we do have also updated guidelines for the use of these antivirals, because the number of antivirals, as you know, is very small, and we are really afraid of general too much using them, and of course, as I said, resistance is there as well. So these are the viruses that have some systemic treatment with antivirals. As I said, majority for HIV/AIDS. However, at these two presentations I'm going to have, we'll face the herpes viruses, influenza virus, and Hep B and Hep C viruses. There's also treatment, as you know, for respiratory syncytial viruses in severe cases. As for other viruses, there are anecdotal or like case reports on treatment, no general guidelines or general use for those viruses, and I'll touch a little bit on those as well. So let's first start with human herpes viruses. Very, very widespread, as you know, more than 100 of them being around in the nature. However, 8 of them performing infection in humans. The general characteristic of all of them, lifelong infections, so you cannot get rid of them once you are infected, latency, reactivation, even oncogeneity, and not curable. So there are several clinical syndromes related to this herpes virus infection. As you know, I won't get into that in detail. However, these are the antiviral drugs used for herpes virus infection. So for herpes simplex, varicella zoster, and cytomegalovirus. However, as you see, the number is limited, and keep in mind that those with 1 star are used for topical use, not for systemic, and the one with 2 stars is used for intravitreal use. So actually the number is really very limited. Let's just have a brief look at each of them. So acyclovir was the first ever antiviral drug that was actually patented already in 1974. However, for medical use, it was approved only in 1981. As you know, it's used for oral, intravenous, or topical administration, and in vitro, it's most potent against herpes simplex type 1, half as potent type 2, and 10th as potent against varicella zoster virus. Most commonly, it's used actually for herpes simplex infections. It's very well tolerated by the patients. It has a favorable safety profile. However, as you know, it doesn't have such a favorable profile regarding the dosage, because it has to be used like 5 times a day. Keep in mind renal insufficiency in those patients, because actually it nearly completely excretes through kidney, which means that patients need to drink a lot. They have to be hydrated well, otherwise it's really a safe drug. What about the pregnancy? Well, actually, no fetal abnormalities has been noticed in vitro. However, no controlled study was done in pregnant females, but there has been a large observational study in 5 European countries, a prospective observational study showing that actually there were no more abnormalities or morbidity or mortality in those newborns born to mothers that got acyclovir during pregnancy compared to those mothers from the general population that didn't get it. So you should inform the pregnant women of that. So no controlled study. However, it's safe to be used in the pregnancy. Valacyclovir. Valacyclovir is actually a prodrug from the acyclovir. It has really advantages. It has oral administration. It has enhanced absorption after oral administration. Its bioavailability is much higher compared to acyclovir, as well as concentration time curve, and it's very well tolerated. Then it's famciclovir. We don't have it in Slovenia, however, generally throughout Europe it's used. It's a guanosine analog, and it's actually a prodrug of a penciclovir, but we do not use penciclovir for a systemic infection, for systemic use. Because it doesn't have such a good bioavailability, oral bioavailability, because the prodrug improves the oral bioavailability of penciclovir. So famciclovir is for oral administration. Its concentrations intracellularly are higher than of penciclovir than of acyclovir. Penciclovir is not metabolized, but it's again eliminated unchanged in urine, so good hydration of the patient is needed. And when it comes to kidney impairment, you must keep in mind that actually the adjustment of the dosage is required. And then here comes the brivudin, the drug that was approved in this millennium. However, it's been widely used because it has a very good dosing profile. It's a competitive inhibitor of rDNA polymerase. It is for, as you know, oral administration, 1 pill a day, very convenient, for example, for old patients who have a bunch of other drugs that need to be taken during the day. And it has very good characteristics because in vitro, the brivudin is up to 1,000 times more potent in inhibition of VZV as well as other viruses compared to acyclovir. However, its only indication to be used, the brivudin, is shingles, so herpes zoster, in immunocompetent patients. Why? Because studies or real-life data have shown that it has to be contraindicated, particularly in patients in combination with 5-fluorouracil, because there have been some fatal cases after the dual combination, drug-drug interaction. There has been a severe increase in 5-fluorouracil after concomitant treatment with brivudin. So brivudin only for immunocompetent patients, but very well tolerated and excellent dosage profile. Now let's proceed to particular viruses, to particular syndromes, and let's see how we can use all those drugs. So you know the virus that causes these clinical syndromes. It's herpes simplex virus, so herpes simplex type 1 and type 2. Generally used systemic drugs are acyclovir, valacyclovir, and famciclovir. However, when it comes to the patient that needs a rescue treatment, then foscarnet or cidofovir, which I'll discuss later, come as an option. So what is the efficacy of these antiviral drugs? Can herpes simplex virus be treated? Not at all. So what can the drugs do? The systemical use can actually speed the healing of lesions. It can reduce the viral shedding. It means it can do well to the individual, and it can do well on the epidemiological basis because it really can reduce the viral shedding, and it is effective in primary and recurrent infection in immunocompetent as well as in immunocompromised patients. So who prescribes it? Well, actually, it's generally prescribed because like for orofacial herpes or genital herpes, this is also the GPs that can prescribe it. So it can be widely prescribed. However, for other indications, other clinical syndromes, it's usually the specialists that need to be taken into account in these patients, and actually they need to do a thorough follow-up of these patients. However, don't forget that, that in herpes simplex virus infection, it's not only the treatment of the disease, but also the chemoprophylaxis that can use these antivirals. And genital herpes is a very well-known indication for acyclovir or valacyclovir or famciclovir to be used. So if we have an immunocompetent person and has a genital herpes and 6 or more outbreaks of genital herpes per year, this is an artificially set limit, however, it's a cutoff limit, and it bothers the patient, then you can give a chemoprophylaxis, which means that you can give a small dosages of drugs once a day, not for 1 month or 2 months. You can have a really prolonged period of giving this chemoprophylaxis. When it comes to immunodeficient patients, of course, the immunoprophylaxis is the chemoprophylaxis of herpes is much more common, as you know, and of course, it's the case in recurrent herpes, in transplant patients, in HIV/AIDS patients, and of course in patients with hematological malignancies. So you won't do anything wrong if you give them very quickly or after the schedule of the infections, this chemoprophylaxis, whereas when it comes to immunocompetent patients, you have to be careful not to make a widespread use, so to give everybody with 2 blisters twice a year on the lips to give chemoprophylaxis. That's not the case at all. So that's why we do have the guidelines, the indications for treatment of infections with herpes simplex viruses. And as you see, these are the guidelines that we have in Slovenia. However, they are made according to the international guidelines. So actually, there are usual drugs that are used are named here. The dosage or the mode of administration you can see here. However, there are different schemes for herpes encephalitis, for immunocompromised with systemic infections, for immunocompromised with mucocutaneous herpes. Usually you treat them with oral administration, whereas of course systemic infection in immunocompromised you would give intravenously. Different schemes for neonatal herpes. As for genital herpes, you have different schemes for primary treatment, recurrent, you see the duration of treatment is different, and of course a recurrent when you give the chemoprophylaxis. For label herpes, please take care when you would give systemic treatment, like for 1-2 blisters, don't give it. However, when it comes to like a bunch of blisters and the patient gets married the next day and she has, everything there, of course you'll give everything to. You have to keep in mind also the particular condition, the particular status, and so on. So why? Because there is resistance already known also to acyclovir, not only in immunocompromised patients, but as you see also in immunocompetent. So far it's low, however, we are very afraid that the widespread use of these antivirals make this resistance even higher. So when it comes to resistance, for example, in patients in immunocompromised that definitely or dreadly need this treatment, then you can use the rescue treatment, but only in this case like foscarnet or cidofovir. Now we're proceeding to another virus. Which one is that? Okay, varicella zoster virus. I just want to see that you're not sleeping. Sorry, I didn't want to ask you. Okay, so varicella zoster, you see, ladies, I deliberately choose a very nice thorax here, So actually, but this one is not so nice. I'll tell you why. So actually, as you know, the varicella zoster virus causes like 2 clinical syndromes. It is the chickenpox and it is the shingles, the zoster. And chickenpox in children, if they're immunocompetent, of course, it's a self-limiting disease. However, when it comes to adult population above 18 years of age, or patient or people or newborns, immunocompromised, pregnancy, chronic pulmonary disease, chronic skin disease, then of course the outcome or the chickenpox can be a very, very life-threatening serious disease. 5 times more complications in adults compared to children. That's why we need treatment. And actually, we do have the same treatment for herpes simplex virus, like acyclovir, valacyclovir, and famciclovir. However, as you see, the dosage scheme is different for herpes simplex compared to varicella zoster virus. Why? Because, as you see, As you see, like for acyclovir, higher doses and more frequent dosing for VZV is needed than for herpes simplex, because actually VZV, as I told you at the beginning, is less sensitive to acyclovir compared to a herpes simplex virus. So the systemic treatment, what's the efficacy of systemic treatment in chickenpox? Importantly, we're actually in immunocompetent, it shortens the duration of treatment and the outcome of the symptoms and signs. However, very importantly, in immunocompromised, several studies have shown that systemic treatment prevents dissemination of the disease, which is really one of the most important indications in this case. So again, we do have very strict guidelines when to use treatment in chickenpox, and please remember them, it's really easy. So everybody who has chickenpox and is aged about 18 years of age, he should get treatment. Everybody, chickenpox, age more than 18 years, treat them. Then, of course, secondary contacts, age 12 to 17 years, pregnant women, patients with complications, and, of course, immunocompromised. Very importantly, start treatment within 48 hours of the onset of first skin lesions. It's very important. You can do it afterwards in, for example, immunocompromised and so on. However, you should do it as quickly as possible. For pregnant women, of course, you should inform them about, you do treat, of course, the pregnant women, but you should just inform them about this no controlled studies. And of course, in patients with highly impaired immunity, you should use acyclovir intravenously. And here is the regimen, again, guidelines, how to treat them. You have everything in your booklets. However, just to explain, you should definitely discriminate between the patients with normal immunity and deficient immunity. And as you see, these are the dosages, usually orally, usually 5 to 7 days. But of course, in immunocompromised patients with severe immunodeficiency, you would give them treatment parenterally. And when it comes to insufficient efficacy of those drugs, you can go to salvage treatment with foscarnet. And then from chickenpox, let's proceed to shingles, so to herpes zoster. You know that herpes zoster is a very annoying disease. It can be also very severe disease, even fatal disease. It can disseminate, it can have dermatological complications due to localization, and one of the most annoying, of course, postherpetic neuralgia. So, what is the efficacy of systemic treatment? It shortens the healing process in acute disease, it alleviates pain, and actually several studies have proved that it alleviates and even prevents chronic complications like postherpetic neuralgia, like more than 30% lower rate of postherpetic neuralgia if you treat acute herpes zoster, very importantly. Again, guidelines, whom to treat shingles. Everybody above 50 years of age. So chickenpox, 18 years, shingles, 50 years. However, even the patients below 50 years of age have shingles. So if they have severe pain, several vesicles at any age, they're entitled to systemic treatment, as well as zoster on head, neck, of course immunocompromised, atopic dermatitis, eczema. It's true that treatment is effective given within 48 to 72 hours. However, you can give it even later in certain group of patients, immunocompromised, of course, including. And again, here is the guideline, the regimens, the indications to treatment, again, discriminating between patients with preserved immunity, deficient immunity, how you treat them, the dosages, and everything. I wouldn't go into detail. However, just keep in mind, zoster treated after 50 years and more. Now, just a touch of cytomegalovirus. This is not a generally known infection to be given treatment. However, as you know, in particular immunocompromised patients do need treatment for CMV infection. We do have DNA polymerase inhibitors such as ganciclovir, valganciclovir, and some of them for rescue treatment. And just a touch of new things that are coming. We do have a new one, viral terminase inhibitor, which I'll just briefly mention. So ganciclovir is the usual drug that is given for treatment of systemic of CMV disease, cytomegalovirus disease. So in symptomatic immunocompromised patients, this is a DNA polymerase inhibitor. However, its absorption in the oral form is very limited, so actually it's given intravenously. However, as you see, it also has a slow release formulation, which is used for intravitreous administration. And we have a topical ophthalmic gel, which is more and more used by ophthalmologists for acute herpes simplex keratitis. You most probably noticed that, but it's already been used. So it can have quite severe side events like bone marrow suppression, particularly leukopenia or thrombocytopenia, and actually the resistant stains are there. They really rarely occur. However, they can occur, but they are usually, luckily enough, sensitive to foscarnet or cidofovir. However, we do have valganciclovir. Again, the valinestor or ganciclovir, it has good resorption, 60% bioavailability, oral administration, and actually its indication is, of course, CMV infection. It can be used for everything, for treatment, for preemptive, or for chemoprophylaxis. However, the dosages and the scheme of treatment is different. And then it's foscarnet. We are afraid of foscarnet. Actually, it's also DNA polymerase inhibitors, only intravenously. It has the same efficacy as ganciclovir, and it's primarily used for CMV retinitis in HIV/AIDS patients. However, it is used also for CMV disease in patients where the ganciclovir failed, either due to resistant viruses, neutropenia, and so on. Just as a rescue treatment, as I told, it's used for herpes simplex and varicella zoster. And then its major toxicity, renal impairment, and of course cross-resistance. Cidofovir, DNA polymerase inhibitor, intravenously, a half-long lifetime, so it can be administered once a week or afterwards even once per twice a week, again primarily for CMV infection. And then, importantly for the future, but it's already there, liposomal prodrug of cidofovir is cidofovir, which is 1,000 times more potent than cidofovir against CMV. It's oral, high blood levels, not nephrotoxic, so whatever you like, it's there. And again, we have a scheme for cytomegalovirus infection, like for prevention, so prophylaxis, preemptive treatment, and treatment. And as I said, novel drugs, it is novel drug, it's the viral, is the inhibitor of viral terminase. We'll hear a lot of it in our future years. However, just a touch of EBV, it's no guidelines. It's just case reports for post-transplant lymphoproliferative disease or hemophagocytic syndrome. Like, we use what we think is best for the patient. And now let's move from herpes viruses to influenza. Just briefly, influenza can be a fatal disease. Everybody knows that. And actually, the baseline approach to management influenza is what? Of course, vaccination. However, this is the... This is the real-life situation of vaccination. Just a very hot one. I took it from the internet yesterday, ECDC report. And as you see, these are the targets of EU. Where are the tigers? I don't dare showing you where Slovenia is. So actually, luckily enough, we do have treatment, systemic treatment for influenza, because it's needed, of course, occasionally. Perhaps some of you still remember the amantans, amantadine, rimantadine, no more use because they are used only, can be used only for influenza A, and there's a high level of resistance. And the generally used treatment for influenza are neuraminidase inhibitors, active against both A and B viruses, oseltamivir, oral one, inhaled zanamivir. There is also an intravenous peramivir, but it's not been registered everywhere. And in the States and in Japan from last year, just to show you what's going on there is a cap-dependent endonuclease inhibitor like baloxavir, marboxil, which is perhaps some of you know already, but it's not yet there, not in Europe. And of course, several countries, if there is an emergency or experimentally or research, use some other drugs that are unauthorized or unlicensed. What's the the benefit of antiviral treatment in influenza? Actually, these are studies, and they show that early antiviral treatment could definitely shorten the duration of fever and illness symptoms. It can reduce the risk of some complications, some severe complications. It can reduce the death. In hospitalized children, it shortens the duration of hospitalization, but actually the only clinical benefit is there if you introduce it early, so especially within the 48 hours of the start of the disease. So the recommendations, both drugs can be used for treatment or prophylaxis. For treatment, as you see, they can, oseltamivir can be used at any age, whereas zanamivir from 7 years on. The treatment duration, 5 days. The chemoprophylaxis duration, 7 days. Keep in mind, no more 10 days. It's 7 days. Actually, the dosage in children is according to the weight, whereas in adults, it's usually 75 milligrams. For treatment, it's twice daily. For prophylaxis, it's once daily. And then, what are the indications for treatment? Well, actually, of course, hospitalized patients, severe, complicated, or progressive disease, and patients at high risk for influenza complications, which are those below 2 years of age and above 65 years of age, people with certain chronic diseases, immunosuppressed patients, pregnant women and or postpartum women, then those who are using salicylate-containing medications, very obese patients, and residents of nursing homes and other chronic care facilities. What's the real-life situation in Europe? The recommendations for the indications for treatment are very diverse throughout Europe, and as you see how many countries in Europe use treatment for high-risk groups, not all of them, for adults above 65, for pregnant women, not even 50% of countries have indication for treatment for pregnant women, and so on. Now we come to chemoprophylaxis, so not yet ill, not being vaccinated, and actually neuraminidase inhibitors have shown to be 70 to 90% effective in preventive influenza. So however, please keep in mind, widespread or routine use of antiviral medications is not recommended for chemoprophylaxis. But there are certain indications for those who have not been vaccinated, couldn't be vaccinated, and being exposed to persons with influenza, like those at risk, like those at risk for complications, people with severe immune deficiencies, and so on. And of course, indication is to control outbreaks among high-risk people. But keep in mind, chemoprophylaxis is generally not recommended if more than 48 hours have elapsed since the first exposure. Again, different indications throughout Europe for chemoprophylaxis. As you see, many countries do not use chemoprophylaxis in residents of long-term care facilities. Or, this is interesting, nearly no country advises chemoprophylaxis for healthcare providers if they are exposed to a suspected or laboratory-confirmed influenza. However, let's have a look at the future. There are several new drugs upcoming. They are in the late phase of clinical trials, so we might expect new drugs coming on this board as well. So to conclude, you see treatment of viral infection generally is symptomatic, however, not only symptomatic, Actually, we do have some treatments, good treatments, but we should follow the indications, and actually special populations should have a special attention. Of course, we do have a help for this lady from the beginning. You see now, when she got chemoprophylaxis, she's very happy running, traveling, and doing something else as well, you know. So here's the literature, it's put there, and okay, that's it. Any questions?
So thank you very much for...
Okay, so viral hepatitis. As you see, Slovenia is really has a good model for the management of viral hepatitis, particularly hepatitis C virus, and I'll be more than happy to go into detail if you have some more questions regarding this. But let's start with the general observation. General observation regarding the viral hepatitis is that actually, this is the report of WHO. In 2015, the number of deaths globally due to viral hepatitis exceeded the number of deaths due to HIV/AIDS. And if nothing is going to be done, by the year 2030, 20 million new deaths will occur due to viral hepatitis. And the vast majority of these deaths, as you see, belong to Hep B and Hep C infection, not at all acute. It's for chronic, as you know, cirrhosis, hepatocellular carcinoma. And in Europe, as you see, this is the same report, 3/4 of deaths due to viral hepatitis are caused by hepatitis C virus. And let's first touch the virus itself. So let's compare the three blood-borne viruses, HIV, hepatitis B, and hepatitis C, because this is essential for the treatment of those three infections. As you know, in HIV, everybody knows what happens, even children, I think, because it's a very well-known virus. So actually, the virus enters the lymphocyte. It enters the nucleus. Not only it enters the nucleus, it integrates into cellular genome, the most criminal thing that the virus can do. And actually, it persists there. In hepatitis B virus, the virus enters the hepatocyte. And during its life cycle, its replication, it enters partially also the nucleus. However, it goes out from the nucleus, but in the nucleus, a part of viral DNA remains, so-called cccDNA, covalently closed circular DNA. So it remains lifelong. Even if you get rid of HBs antigen and you think you are cured or whatever spontaneously, you are not actually. cccDNA persists in the liver cell in the nucleus. However, there is a benefit of the nature in hepatitis C virus. Everything regarding the replication cycle is done within the cytoplasm. The virus does not enter the nucleus. And as you know, there are several enzymes needed for this replication, like polymerase, like protease, and we do have the technology to block, to inhibit those enzymes because the virus does not enter the nucleus. We have no drugs so far to make virus get out of the nucleus or to kill the virus inside the nucleus. However, we have several potent technologies to make the drugs for the viruses in the cytoplasm. And that's why actually there is a lifelong persistence of cccDNA here in HBV. There's a lifelong persistence here. So the treatment can just suppress the infection of HIV or HBV, but it cannot cure it. Whereas in HCV, of course, treatment can do everything. There's no reservoir anywhere. There's a clearance of the virus, and it can be cured. So this is very basically, I'm sorry I'm explaining it so simple, but that's how it is actually. So HCV is actually the first ever cured chronic viral infection in medical history. It's a huge thing, you know. We should speak more of it. It's like penicillin 100 years ago for bacterial infections, you know. And unfortunately, HBV, HCV, we are not there yet, but we are doing on that. And it is anyway, we do have drugs, and these are well-controlled chronic viral infections. So the burden of those two hepatitis viruses is quite huge. These are the numbers of chronically infected now in the world. However, it is a very obscure and occult disease because it doesn't show usually. So actually the infection has been diagnosed in very small proportion of people, and those who know that are infected, the treatment is very low. The proportion is very low. So the baseline problem is not on the individual level, it's on the public level, public health level. So infections have to be diagnosed and then they have to be treated. So let's first proceed to hepatitis C, which my favorite actually. So hepatitis C, just to show you what it can do, it can damage the liver, and of course it can be fatal due to decompensation and HCC. However, I'm sure you're aware of that, it can cause several extrahepatic manifestations in up to 3/4 of the patients, either due to immune response or either due to metabolic mechanism. However, we do have drugs, and this is the timeline of the drugs against hepatitis C. As you know, we started with very unfavorable and unpopular interferon, injection subcutaneous, 12 months treatments, severe side effects, even life-threatening, very unfavorable even for medical doctors, not only for the patients, a real nightmare. However, there was adding of ribavirin, the PEG form, optimized treatment, but then the period of direct-acting antivirals came. First, there was the first line, which was not so good because it still had several side effects and not being so very effective. However, when it comes to the second line, then we are there. So this is the efficacy of anti-HCV drugs. SVR means sustained virological response, virus getting out of the body, people getting cured. So with optimized PEG interferon riba treatment, just half of patients got treated. These are the general results of clinical studies. In Slovenia, we had much better results, but I'm showing the general ones. And with the new drugs, as you see, nearly everybody gets cured. So what's the point of these drugs? We have polymerase protease inhibitors, we have polymerase inhibitors, we have NS5A inhibitors, and we have the combination of all those drugs. So actually the first line, these four of them, some of them were meant for one genotype or for another. They have some side effects. They were not so favorable with the drug-drug interaction with the baseline drugs. However, there's a second generation that's now used. It's pan-genotypic for every patient, nearly no side effects, and so on. However, we already have mutations here, so resistance. They're called RAS, resistance-associated substitutions. I won't get into detail. However, they're very rare, but they exist. And just keep in mind, no more new drugs are being produced. So hepatitis C, we are done. We are there. We have all drugs that we need. So actually, we really have to be careful to choose the proper drug. But we do have a joker. A joker is voxilaprevir, the last one in combination with fosfolipid paltusvir, and actually it's efficient in those patients. We have it in Slovenia as well, and it's really the good one. So these drugs are really patient-friendly, no side effects, one pill a day, pan-genotypic, whatever you can imagine, except for one thing. They are quite expensive. It depends on which country you live, but the first drug, which was sofosbuvir, this was one pill, $1,000. It was difficult to swallow even for the Americans. So actually the price has gone down now, and every country has negotiations with the pharma. So actually the main problem now for the countries are to get the drugs into their country. When it comes there and the people can get treated, then is no more problem. So which combination to choose? We do have the international guidelines. This is European Association for the Study of the Liver, the most important and powerful institution that gives these guidelines. So actually, we are going into the same way as HIV, test and treat. If the patient is positive, treat him, because you'll have the double benefit for the patient and for the public health. So it's used actually for all the patients. We do have the very precise guidelines. I won't go into it for genotypes. Either you have pan-genotypic or non-pan-genotypic. But keep in mind, drug-drug interactions here are very important. So it's one of the important issues that you need to think it over when you decide on which treatment to give to your patients. So actually the benefit is immense. It's a benefit on the epidemiological level, because when you cure a drug user, and you know the drug users are the driving force of this infection, when you cure the drug user, he won't transmit infection, because it's been generally speaking, the studies have shown that in 5 years you can prevent 15 new infections if you treat one drug user. However, it depends in which country you are and what's the epidemiological situation. And on the individual level, of course, it improves the clinical outcome, either hepatic or extrahepatic. So the take-home message for hepatitis C, we do have potent, simplified therapies. These DAA have short duration, oral, effective, no interferon, not affected by genotype fibrosis mutations, resistant, rare, and manageable risk of drug-drug interactions. So everything what we can desire. Great. Now hepatitis B, it's not that great actually. So you perhaps know there is a new definition of the natural course of hepatitis C. We don't speak anymore of HBs antigen carriers and chronic hepatitis, but we do speak of two different conditions. One is HBe antigen positive and another is E antigen negative. And both have either infection or disease or hepatitis. So now this is the curve of the natural course of infection, and the new nomenclature, which is quite important because we'll have to change it now in our minds as well. So we are speaking of E antigen positive chronic infection, E antigen positive chronic hepatitis, or E antigen negative infection and E antigen negative hepatitis. Why is it so important? Well, it's important because of the clinical course of the disease. Because as you see here, these are two completely different diseases regarding the outcome of the disease. So as you see, high proportion of E antigen positives going into cirrhosis compared to very low proportion in E antigen negative, the same with HCC and the same with death. So actually, we are not speaking of one disease when we're speaking of hepatitis B, but there are two different diseases, E positive and E negative. Now, regarding the drugs. Well, this is the timeline of hepatitis B therapy, which started already in the 80s with interferons. Even we started to treat some of them with interferons, but when at the late 90s of the previous century, lamivudine came. Lamivudine was actually meant for treatment of HIV/AIDS in 92. However, it wasn't so well in that field, but it was much better in the field of viral hepatitis. And then a new one came, sadefovir and tekavir, PEG interferon, and so on, and the new ones, new formulations of tenofovir. So, if we can still use interferon in particular patients, very particular patients, very limited ones regarding the genotype, the age, and the form of disease, interferon is used up to 48 weeks, whereas nucleoside and nuclear analogs are most probably used lifelong because they have to suppress this cccDNA inside the nucleus. If you get rid of these drugs, then the virus has, party there. Okay. So what is the goal of this treatment? It improves survival, definitely. It prevents disease progression, definitely. It prevents development of HCC, definitely. So the endpoints are, first, get rid of viremia, HBV DNA 0. Normalize transaminase, so transaminase normalize. Get loss of HBe antigen, not so often. Get rid of HBs antigen and appearance of anti-HBs, very, very rare. Not possible to eliminate cccDNA. Okay? So you can control it very well, but you cannot cure the disease. So what's the outcome after 1 year of this treatment? As you see, this is the percentage of HBs antigen loss. Very bad. The best with PEG interferon riba. In E antigen positive ones, in E antigen negative, it's even worse. So actually, you can control the disease very well, but you cannot cure it. That's the case. If you want to control the disease, then of course you have to follow up these patients. Oh, what did I do? Okay. Because there is already the possibility of mutations and, of course, of resistance to these drugs. With lamivudine, generally speaking, the first nucleoside analog, there was, after 1 year of treatment, 20% of patients got resistance to lamivudine. After 5 years of lamivudine, 70% mutations occur. So actually, you really have to be careful. You have to follow up these patients and monitor them very carefully. However, we do have Okay, so how to treat these patients? Again, European Association for the Study of the Liver gives us the perfect guidelines. It's updating, of course. However, when it comes to your particular country, you have to always do, it's the same for hepatitis C, your own national guidelines. Usually guidelines are based on some international guidelines. However, you should to take into account your national particularities. And for example, in Slovenia, we have a very low percentage of resistance to lamivudine. So actually, we keep patients on lamivudine if it's not resistant, you know. Why not? Why change the drugs? But it's not the case, for example, in Italy or in Austria or in some other countries. So the EASL recommendations are very clear regarding treatment of patients with chronic hepatitis, very strict. So we don't treat every patient with chronic hepatitis. We treat him when it comes to certain stage. Then we have special groups of patients, pregnant women, healthcare workers, and so on. Then we can also very quickly give the treatment in some special groups, such as those aged above 30, particularly if they have HCC in their family history. And then regarding treatment of acute hepatitis, do you treat acute hepatitis B in your countries? Do you know? Sometimes, that's right, that's the right answer. What is sometimes? Definitely you need to treat acute hepatitis B when it's severe course of the disease, because you definitely need very quickly to get aviremia, you know, because then the body will have much more power actually, or immune response to cope with the disease. So acute hepatitis B, the severe one, is definitely the reason to treat with antivirals. And what is the efficacy of this treatment? Well, several studies have clearly shown that compared to placebo, it reduces HCC, variceal bleeding, renal impairments, and so on and so on. So actually, there is a great benefit of this treatment. However, it's a lifelong treatment. And then we come to immunosuppressive treatment, to chemoprophylaxis. We have patients on going to immunosuppressive treatment, and they might be infected with hepatitis B. And as you see, if this is a patient on chemotherapy, when you stop chemotherapy, then iris emerges, immune reconstitution syndrome, and actually the patient can die of viral hepatitis B, of fulminant course. So for that reason, we have to check every patient before undergoing immunosuppressive treatment for hepatitis B serological markers, and you have to think over then on introducing the chemoprophylaxis, because you see here, if you give lamivudine, like 1 week would be great before onset of the immunosuppressive treatment, then there's no more reactivation, nothing. In Slovenia, we did our guidelines for that in 2008, and we have a special outpatient office just for those patients. No waiting time, of course, nothing, and infectologists are engaged in this prescribing this chemoprophylaxis. Why? Because the pipeline of the immunosuppressants is getting larger and larger, as you know. And the most potent activator of hepatitis B virus is rituximab, you most probably know. So please keep in mind, if your country doesn't have guidelines for this, do it on the national level, because we did it very seriously. I personally visited all the associations of the specialists that are dealing with immunosuppressive drugs, and actually since then, we had no fatal cause of viral hepatitis B due to reactivation. And then there's another use in pregnancy. If it comes to certain cutoff of viremia in pregnant women, then you should introduce antivirals and take or best tenofovir, and then it's proven that actually it lowers the transmission to children significantly to the newborns. I do hope that your pregnant women are checked for HBs antigen in the first trimester. That's very important. And of course, do we have some? Okay. Again, the future is there. We have several new researches on different targets for hepatitis B. Just name it. So actually, now hepatitis C is no more individual problem. Now hepatitis B became the real challenge for the scientists to make new drugs, to to try to get rid of this CCC DNA. So take-home message for hepatitis B. As you see, we have new classification of the disease, and we have additional indication for treatment. They are a little bit wider than they were some years ago. However, please keep in mind, do take care of these guidelines for treatment with hepatitis B. And just a touch of my 53-year-old male who was very good, in good shape, no particular diseases, and all of a sudden he had very strong pain in his shoulders. He couldn't move them. That is all that he could do. What was the cause of this? Actually, this patient had acute hepatitis E. He was not immunocompromised. However, he was a hunter and huge lover of sausages, homemade sausages. Actually, this is acute hepatitis E, autochthon in Slovenia, severe neurological symptoms. He had a neurologic amyotrophy, so this is all what he could do. What's the treatment for that? Do we have any treatment? It's hepatitis. Excellent. So actually, the treatment for hepatitis E is not particularly made for hepatitis E virus, but we try with ribavirin, perhaps immunoglobulins. This patient got them because he had positive lumbar puncture as well. Plasmapheresis, some of them say, but it's not there. You also have very extent guidelines for management of hepatitis E. Again, these EASL guidelines, you can Google them. And for immunocompromised, as you know, hepatitis E can do really a lot of damage. It can cause chronic infection. I hope you know that. E hepatitis can be chronic in immunocompromised. So this is one of the schemes that is actually recommended nowadays, but we are all expecting new drugs so some development in going in that way too. This is the literature, and I hope you are aware that we have the first drug for viral infections, and we do hope in future there we have some more. Don't forget, hepatitis B is a preventable disease. So I do hope you do have national programs for vaccination, and the coverage of vaccination is much higher compared to influenza. Thank you. Okay, and now let's proceed to the favorite theme. This is HIV/AIDS, and who else than Professor Janez Tomažič is the best person to deal with that, because he's running the department actually, or the unit for HIV/AIDS in Slovenia. So please.
Thank you very much. So everything started more than 35 years ago. A devastating disease with grave prognosis, stigma growing into world's epidemic. And at that time, most important thing was to keep those affected alive, opportunistic infections, and increase knowledge. Nowadays, we have powerful weapons, and within a decade, mortality was reduced from 20% each year to less than 2%. And there are two big hallmark studies about the strategy of antiretroviral treatment. One is a START trial. ART must be initiated as soon as the HIV infection is diagnosed, and the other one is SMART trial, an old one. It can never be discontinued. So there is no treatment holidays. And if we look at these Kaplan-Meier curves, here, if there is a deferred initiation of treatment, there is close to 60% more events, AIDS events, or death. And similar is if we stop treatment, we can see that there's also these events taking place because virus rebounds. So today, ART antiretroviral treatment, a highly active antiretroviral treatment, is more simple and easy. Mostly we treat with STR, single tablet regimen. They are more safe, sustains long-term viral suppression without problems of emerging resistance. So now we are moving from individual to the public level. Very important, treatment as prevention. Treatment is most important, of course, to suppress virus, restore immune defense. And of course, equally, it's important for prevention. So community viral load is very important. And if we have a look at this graph, if we involve in treatment more persons living with HIV, then the incidence of new diagnosis is decreasing, and this is happening even in a subgroup of people who use drugs. Very important. And this is another study, breaking through study, 052 from 2011. HIV transmission is reduced by 96% in sero-different couples. And as I said, treatment as prevention. People with HIV who take HIV medicine as prescribed and get and keep an undetectable viral load have effectively no risk of transmitting HIV to their HIV-negative sexual partners. So probably all of you know undetectable is untransmittable. And this is very important syntagma, not for discrimination, for stigma in public life, and also in healthcare settings. So we have really powerful data, and this powerful data come out of Australian study and also Western countries. So these two recent studies in MSM, serodiscordant couples, confirm that viral suppression prevents transmission of the virus in case of high risk, unprotected anal intercourse. Even other STRs are present. So very important data. Now we'll go to guidelines. So in Europe, we use European AIDS Clinical Society EACS guidelines. There are also EAS guidelines, DIHS guidelines, and recommendation for an initiation of ART in HIV-positive persons with chronic infection without prior ART exposure, so-called treatment-naive patients. ART is recommended in all adults with chronic HIV infection, irrespective of CD4 counts. So the lower the CD4 count is, the greater is urgency to start. Now, you know, is test and treat immediately. So we have now also very powerful new drugs that we can afford that. Okay, in persons with opportunistic infections, there is some delay with cryptococcal meningitis because of iris, immune restoration, inflammatory syndrome, so we wait for 4 weeks, and also with TB, it depends of CD4 count. If it is below 50, we wait 7 days, 7 to 14 days when the person, you know, is acquainted with anti-tubercular treatment, accept these regimens. But if CD4s are higher, we can wait even 8 or 12 weeks. So this is standard of care for treatment. Standard of treatment, combination of 3 drugs. So we use still in a backbone R2 and RTIs, plus a 3rd drug, and that's integrase 10 transfer inhibitor, or shortly integrase inhibitor, and non-nucleoside reverse transcriptase inhibitor, and protease inhibitor. And here's a timeline of our drugs. So very important was the beginning of highly active antiretroviral treatment was in the second half of 19th. Very important drug was efavirenz. Very important was lopinavir, ritonavir, Calitra. So we were very successful with these drugs. Then breakthrough with integrase inhibitors in 2007, raltegravir, and 5 years ago, very important drug, dolutegravir, and last year it's bictegravir, and we started this year to use this very important integrase inhibitor. So we'll go next step to HIV life cycle and treatment targets. So entry inhibitors, nowadays we don't use them. You know, fusion inhibitors, we had some experience years before, but these are newcomers, so they will be in near future important. So now main targets are 3 enzymes: reverse transcriptase, integrase, and protease. So it's not complicated as it looks at the first glance. So we use, as I said, 2 nucleosides plus a third drug. Mostly now we use integrase inhibitor. Then we can use non-nucleoside reverse transcriptase inhibitor, or as a third drug, protease inhibitor. So here are recommended regimens, and one of the following should be selected. As I said, now the third drug is integrase inhibitor, so we can use dolutegravir or bictegravir or raltegravir as a backbone. The best now is TAF, tenofovir alafenamide, because if we compare it with abacavir, for abacavir we need genetic testing. For abacavir, you know, comorbidities are now issue, and abacavir has some heterogenic characteristics, so we avoid this drug. And TDF, tenofovir, the old one, has a toxicity to bones and also to proximal tubules, to renal impairment. So TAF is the best. Of course, it's also the most expensive, so it can be in fixed combination, the SCOVY. But now we'll have a look at integrase inhibitors. Here are advantages and disadvantages of current available integrase inhibitors. The big one, the last one, is bictegravir. It is in a single tablet regimen as Biktarvy. It is not inferior to dolutegravir, so here is a head-to-head study with bictegravir and this combination with TAF and dolutegravir. This is Biktarvy compared to Triumic, you know, and you can see after 24 weeks, both are very efficient, close to 100%, so this is big success of this new regimen. Even after 4 weeks, it's 80% successful. That means 80% are undetectable. So persons that had high viral loads, over 100,000 copies, etc. So very powerful drugs. And so as I said, bictegravir is not inferior to dolutegravir. It's once-day dosing. It's high genetic barrier, very important. I'll tell you later. It has relatively few DDIs, can be taken with food or without. Dolutegravir similar, and raltegravir longest safety record, fewest drug interaction. That's sometimes important because, you know, we have comorbidities with cancers, etc. And what's the disadvantage of bictegravir? We cannot use this in pregnancy and with TB. That's most important. What about dolutegravir? Higher rates of insomnia and headache, so some central nervous side effects. And so when we use it in the morning. And what about raltegravir? Has low genetic barrier, very important, and higher pill burden because you must take it twice a day. We look at resistance, fold of change versus wild type. Even you are not experts, you'll observe that bictegravir has the lowest, and that's important. And what about human plasma half-life? We can see bictegravir has the longest pharmacological forgiveness. If you forget, you know, to take medication, that's important. And also, this is a lifelong treatment. It's very important, the size of the pill. And this is the smallest with Biktarvy. This is Genvoya, and this is Triumic. And that's important for many persons, you know, it's convenience and quality of life. So now we continue with 2 NRTIs with NNRTI, we have rilpivirine and a new drug. I don't know if you are familiar with that. We have doravirine, that's second generation NNRTI. And you can see the efficacy of these are lower than integrase. And they have also, they are not high genetic barrier. There are problems sometimes to take with food or no food, and with some side effects. And this is comparison with doravirine head-to-head to older NNRTI, efavirenz, you know, all of you, with problems of CNS. And the last combination, two NTIs plus PI, and this is known Flamingo study, comparing dolutegravir with darunavir. So integrase inhibitors are coming. Of course, they are most expensive. There are some problems with access. And these are footnotes for AACS guidelines. So there are a lot of things to be taken into account, to be considered. And here are alternative regimens that I won't go into details. So, you know, still there are problems. Still GPs are not taking care, completely of this patient. Even in UK, they don't want to take care and follow up and monitor these patients. There are still some points to be considered, and it's important that you have a lot of experience and knowledge of this field of medicine. As I said before, genetic barrier of the regimen is very important. Why? Because of transmitted drug resistance. And if we look at in Europe, so you are infected in average close to 10% with resistant virus. In North America, it's like that. And if we have a look at geographic trends, we can see in Europe, overall, this transmitted drug resistant is decreasing. And that's important also because we treat more and more people, and we have good medication regimens. So if you look at sub-Saharan Africa, it's some kind of worrying about this transmitted drug resistance. It's not very optimistic. So resistant testing, if I mention just in Slovenia, we have the lowest transmitted drug resistance, less than 2.5%, because we traditionally used a lot of PIs, and PIs are a high genetic barrier, and that's very good, and we are very proud of that. But guidelines, resistant testing in drug-naive individuals is recommended at the time of diagnosis to detect potential this resistance. And then about switching strategies for virologically suppressed persons, so persons that are undetectable, they have virus below 50 copies per mil. So we decide, of course, to switch because of documented toxicity. Let's say if you still use efavirenz, we know central nervous system adverse events, PIs, diarrhea, PIs, DDIs are very, very important. So if you have comorbidity, polypharmacy, don't use PI, you'll have a lot of troubles because now integrase are easier to prescribe. And prevention of long-term toxicity, avoid serious, as I said, drug-drug interaction, planned pregnancy. Integrase inhibitors are not for pregnancy. There are some problems with teratogenesis. So usually we use tenofovir, emtricitabine, and rilpivirine. Also efavirenz could be used. So it is important. There are strategies, I won't go in details because you're not supposed to be expert on this field. Aging and the comorbidity I mentioned already, and of course simplification, STR, and when you start co-infections. So now, I don't know if you're familiar So still standard of care is a 3-drug regimen, but now 2-drug regimen is coming for experienced patients. We have SWORD 1, SWORD 2 study. It's a very powerful study, so you can change, you can switch from 3-drug to 2-drug regimen for experienced patients that are undetectable and that they don't have resistance mutations towards rilpivirine and the dolutegravir. You know, this fixed combination is EUCIC. We have it already here, and there is another for initial treatment, for treatment naive, is Gemini 1 and 2 study. It was presented this summer, but there are 48 weeks data, and we are not very satisfied. And this is combination of dolutegravir plus 3TC for the initial treatment. There is a lot of philosophy behind this 3 or 2-drug regimen, but most of HIV experts, they still would be in safety part of treatment because we don't know about reservoirs, we don't know about what's going on, chronic inflammation, and there's still time and this initial treatment is not in guidelines as the first line, but it's optional. So this is still something to be going on, these problems. And there is virological failure. Of course, that means that you have viral load over 200 copies per ml after 6 months of treatment. And you must always review adherence, compliance, tolerability, drug-drug interaction, drug-food interaction, and psychosocial issues. Sometimes consider TDM. This is therapeutic drug monitoring. Many countries have it. We don't have it. We don't use it. We don't have a lot of problems with that because our population is MSM. That means that they are very cooperative, and we don't have many problems in this part. And of course, there are side effects. And for abacavir, I already mentioned cardiovascular. For TDF, I also mentioned about bones and kidneys. Efavirenz we don't use a lot because of depression, also suicidal attempts and mind about that. Rilpivirine has also some central nervous system adverse effects. And what about PIs? PIs have problems, especially with dyslipidemia. So many patients that are taking PIs are on statins, and dietary is very important, and a lot of DDIs and other problems. So we have very good website. Some of you are for sure familiar with Liverpool drug interaction website. It's easy. You just put your antiretrovirals and medication, and then you can. But it's important that you know it and that you do it. So I'll stick a little with comorbidities. So beyond undetectability. So now we are successful with treatment. A lot of patients that you see, as you saw, are undetectable, but there is still some inflammation going on in their bodies. And we say, so this syntagma is important beyond undetectability, and some antiretrovirus are like abacavir, could be the reason, and HIV virus itself. And so we are very now infectious disease. Now we are internal medicine specialists also, because we must take care, about these comorbidities. As cancer, cardiovascular disease, substance abuse is coming, and people who are taking recreational drugs are also tend to be more dangerous for these comorbidities. Renal disease, of course, liver disease, second most common cause of mortality after HIV itself are hepatic problems. CNS disorders, cognitive disorders, they're coming. Though the patient is undetectable, there could happen cognitive complications, so you must be careful. And the EUCIC guidelines are very good for comorbidities. For example, for depression, there are a few sentences that you routinely ask your patient, and also for cognitive disorders and bone disease. So it's important that you know these comorbidities, that you know these algorithms that are in EUCIC guidelines, how to stick with hypertension, when to give the ACE inhibitor or calcium antagonist. So 55 years of age is a border when you have less or more renin in your body, and also about diabetes, etc. And you must have also, so interdisciplinary approach is very important. So in Slovenia, we have specialists that we can send our patients that are a little more, educated about HIV and comorbidities. So we have cardiologists, we have psychiatric, psychological. They come to our clinic twice a month. Because of stigma, they don't go to psychiatric hospital, but the doctor, they come to our hospital, and it's easy for our patients to pay them a visit at our hospital. And of course, we have diabetologists, the proctologist, very important, because anal cancer is one of most frequent non-AIDS cancer, not directly linked to immunodeficiency. So these are diagrams that from studies that you can see when you are 55, and a population without virus and population with virus. We can see this change. So I won't go in this 90-90-90. So 90% diagnosed, on treatment, undetectable, and also the fourth 90, quality of life. One sentence, prevention of one transmission brings savings a lot if PrEP is applied in those at high risk. So ET's number needed to treat is about 15, so it's very efficacious. And the cost of care for those diagnosed with CD4 below 200 is at least double. That's very important. So the test early, that's important for an individual and for the community and for public per se. So screening, high-risk individual, if negative, you should continue risk assessment, PrEP, adherence counseling, and positive linkage to care, and treatment as prevention, early treatment initiation, undetectable, and of course quality of life. And so testing, test positive, care continuum, testing, test negative, prevention continuing, stigma, one most important problem now for our persons living with HIV. So there are society factors, causal factors. I won't go into details, but I just stop and ask you for questions.
So I'm kind of asking my chief, actually, Associate Professor Dr. Tatiana Leko, to give us some insights into the antifungal treatment.
Well, I'll try to be short, because we have still a lot of work to do, unfortunately. So speaking of antifungal drugs, we know that the problems with invasive fungal infections are growing in the last years because of the changes in treating the patients with hematological malignancies, cancer, and other diseases that need biological drugs. This is a new risk factor for many invasive fungal diseases. And so we now know that there are new risk factors, there are new fungal pathogens. We talked the day before about MALDI-TOF and very exotic bacteria, and so there are also some new fungi isolated. The problem is that we have to make an early diagnosis, and we have to institute appropriate treatment as soon as possible if we have a very immunosuppressed patient. Every hour counts if we want to have a successful outcome, but sometimes we don't know exactly what's happening. The clinical presentations are non-specific. The lab tests are usually are not available, or they are really not helpful. And we know that the basic test, like a culture for fungi, usually is missing, or it's very, very late. So it doesn't help us. So there is is estimated that in more than half of the cases, the antifungal treatment is inappropriate, either because we did not find the fungi and we treated the patient, or either we did not give the right antifungal drugs. These are the groups of antifungal drugs which are now available. The cornerstone of therapies are polyens, azoles, and echinocandins. Other drugs have specific indications. Some of them are old, some of them have a lot of side effects, and the major problem with most of them are interactions. I will not talk about the drugs, because you can look at pharmacy book and you can read what is the indication, contraindication, because in your daily practice, if you are not working exactly with immunocompromised patients, you probably won't see a lot of invasive fungal infections, and you probably won't need to treat a lot of patients with antifungal drugs. But let's talk about the antifungal stewardship, because this is the aim of this course. So very rarely we discuss the antifungal stewardship. Question is it, sorry, okay. Is it necessary, first, like in antibiotics? Why is it necessary? And how shall we do it? So the definition of antifungal stewardship is that these are the coordinated intervention with which we monitor and direct appropriate use of antifungal drugs with the aim to achieve the best clinical outcomes, and in this way we also try to minimize selective pressure and adverse effects. So these are our goals. What we have to consider in the prescribing antifungal drugs, and what managers, CEOs know maybe better than we, is the high cost of antifungal drugs. If we look at the data from University Medical Center regarding the use of antibiotics and antifungal drugs, the use of antifungal drugs is really less than 20% of the antibiotics. But if we look at the costs, those 20% cost the same as all the antibiotics in the hospital. So the cost really is an important issue, because we can, shorten the treatment, change the treatment, de-escalate the treatment, so we can lower the costs. And of course the toxicity. There is no antifungal that is not toxic. The most safe is, of course, as you know, fluconazole, but it has very limited indications. It's actually not useful in patients where we have a broad a differential diagnosis regarding which fungus is the cause of the disease. And lately, what is something that we are afraid of is that there will be an emergence of antifungal resistance, like we see it in bacteria. So what we have to do if we want to establish antifungal stewardship, first of all, we have to know local epidemiology. Do you know what is the percentage of non-albicans species isolated from your blood cultures? We know it's about 40 or more percent. So that means that in 60% you get it right when you give fluconazole, and in 40% you miss. Do you know what is your percentage of Aspergillus niger in your or tereus in your isolates? We don't have exactly the data, so it's, excuse me?
We know the incidence because
Yeah.
to make the diagnosis of aspergillus, you have the clinical and microbiological. It's not just culture.
Yeah.
We
Yes, but that's the point in fungal diseases. Usually you have biochemical markers like galactomannan, you have CT scan, you have a patient with risk factors, but you don't have the bug. So that is one thing. The best thing is that we have a continuous surveillance, that we have a good mycological laboratory which supplies us with data. You have to have some guidelines. The guidelines for antifungal treatment are regularly changed. But if you are reading them concisely, you see that what are the changes. Sometimes they add an echinocandin, which is probably just the same as the other ones. Sometimes they change one azole for another. Sometimes they change the order of which drug is the best and which drug should follow. But in last 15 years, I can say that there were no major changes, except the last one where isavuconazole was registered and it came as a drug of first choice for treatment of aspergillus. Not in all guidelines, and we are still expecting new ESCMI guidelines. What about withdrawal or de-escalation? Do we treat on and on and on and on, or do we try to withdraw the agents? The problem is empirical therapy. When to stop the treatment if the patient is not doing well and if the patient is really immunocompromised. So in treating severe invasive fungal infection, you really need to have a coordination between clinicians, infectious disease specialists, and microbiologists. And just to inform you, there is a meeting of hematology on the other side, and they are the most difficult nuts to crack when it comes to instituting and stopping the antifungal treatment. We really need rapid and reliable diagnostics. And of course, it's good to have therapeutic drug monitoring for antifungals when it's useful. And, but our CEOs will do auditing for the use of antifungal drugs when they see the enormous costs when we treat just one patient with liposomal amphotericin. No, the problem with resistance is rising. That is, of course, true. But we have to know that it is not just microbiological resistance. Yes, there are some species which are intrinsically resistant. Some can acquire resistance, but the patient can be clinically resistant because his or her immune system cannot be reinstituted, and this is one of the most important factors in treating invasive fungal diseases. If you do not raise the number of neutrophils, probably you can give everything you have of antifungal drugs and you will not treat the patient. The primary resistance is really very rare in Candida albicans, and there is quite low in in some of the non-albican species. We know that Candida krusei is, of course, intrinsically resistant, and Candida glabrata has a varying degrees of resistance. So if you have a situation like in University Medical Center Ljubljana, where more than a third of the isolates are Candida glabrata, it's clear that you cannot empirically start treatment with fluconazole. Of course, there are some increasing number of rarer Candida species. There is Candida auris. Maybe some of you know it, the pathogen. We did not meet it yet in Ljubljana, but from the literature, I see that this can be a really nasty problem because it has a very high capabilities of spreading in the hospital environment, which is not usually the case with fungal infections. We don't really have a problem with spreading Candida from patient to patient. What we have is the problem with air and maybe with infusions, but the contact insulations are really not needed for fungal infections. So, if you look at Aspergillus, there is a collection of Aspergillus fumigatus clinical isolates was In Italy, they collected 533 clinical isolates, and you see for the long period of time. And what is interesting is that before the year 1998, there were no resistant isolates. And since 1998, the resistance rate is growing. Now they have about 6% resistance. Don't ask me why. I don't think that there is any good explanation. We know that the use of azoles is high, and that voriconazole was used extensively, posaconazole was used as prophylaxis, so maybe this is some of the reasons why the resistance is increasing. I also suspect that the use, long-term use of azoles for treating, like, chronic bronchitis, asthma, and semi-invasive aspergillosis also has also contributes to increasing resistance. The limits of this study are, of course, quite a few. The clinical data were quite poor, and the problem was that the clinical data did not tell about the role of aspergillus. Was it a pathogen? Was it a colonizer? And of course, there are no data on antifungal treatments, and some of the isolates did not grow. When they looked at patients who were treated with who had voriconazole susceptible and voriconazole resistant invasive aspergillosis, they found that the resistance was 90%, and the most important risk factor was hematological malignancy, like as an underlying disease. And what they found was that this resistance was associated with an excess overall mortality at day 42 and at day 90. This is really important data because it's very difficult to prove that resistance really causes poor outcome in these patients. So what are the consequences of inappropriate therapy when we are talking about invasive fungal infections? We know that you should start the treatment as soon as possible. This is one of the studies which looked at the bloodstream infections caused by Candida, and they looked at the treatment. There was almost 150 episodes of bloodstream infections. What they found is that 10% received an inappropriate treatment because the Candida was either resistance intrinsically or acquired resistance. The 30-day mortality was 38%. There were various factors associated with 30 days mortality, but not the initial treatment. So sepsis, cirrhosis, and so on, this was all associated with poor outcome, but not the initial antifungal treatment. So we know that if you delay with diagnostics and you don't start appropriate therapy, it ends bad for the patient in broad array of fungi, like Candida, Aspergillus, mucormycosis, and of course also pneumocystis. And we know that clinical outcome is poorer for the patients infected with Candida species who are intrinsically resistant for fluconazole or voriconazole. We also know that if you use fluconazole as prophylaxis, you can get a breakthrough infections with resistant species. The other element which we have to talk about in fungal infections, the other element of stewardship is rapid and timely diagnostics. I think that galactomannan is used everywhere. And it is really a useful test, but it is best if we use it serially, not just once. And if we combine it with PCR testing, or when it is integrated in care paths for the patients. Also, beta-D-glucan is useful, but is non-specific, although in pneumocystis is really very, very good tool. So we have other methods. We mentioned 2 days ago T2 based on magnetic resonance. It seems that this is very useful for diagnosing fungal infections. We are now initiated study in our intensive care unit and in some other units in University Medical Center, and we see what will be the result. I know that some of the centers in Spain are already using it with quite a good results. Maybe somebody can comment on that. Aspergillus PCR will be now included in the criteria of EUCIC definitions. And we come to the one other element of antifungal stewardship, that is therapeutic drug monitoring, which is mainly used or mainly done for azoles. For other antifungal drugs at this moment we don't have this monitoring, and the fact is that when you do this monitoring, you see that the plasma levels of azoles are really variable. We have experience with voriconazole, not with others, but the data from the literature show that there is the clearest relationship between drug concentration and therapeutic efficacy. The clearest relationship is for itraconazole. But there is not such a correlation between itraconazole levels and the adverse effects. What we use a lot is voriconazole measuring of voriconazole levels, and this is really a huge surprise. You are giving the patient the correct dosage, which is in SMPC, and the patient doesn't have any levels of the drug. All the levels are below the therapeutic norm. So we know that there are a lot of variations in metabolism of voriconazole, more than variations of absorptions, and I really suggest that if you have the possibility, that you monitor at least levels of voriconazole. Because levels of posaconazole are more related to the function of absorption. You know that the drug has to be taken with fat. Some patients do not like that. Some patients cannot do it. Some patients have diarrhea, and these are the problems with absorptions. So, and one of the things which is touching on the inappropriate or overuse of antifungal drugs are antifungal combinations. What is the rationale? Why should we use those combinations? Well, we can say that we expect improved treatment efficacy because the drugs have different mode of action, like synergy in bacterial infections. We can postulate that the resistance is less likely to develop if we use two different drugs. We can also say that maybe we will treat the patient in shorter time, and we expect less side effects. But this one is merely more optimistic thing. What is the opposition for the antifungal combinations? That we can get antagonism between active ingredients and not less but more adverse effects, like greater toxicity because there are more interactions, and we really just don't know how these interactions will affect the treatment of patients. Of course, the side effects are also higher treatment costs. There are very few good data. You have a lot of studies, a lot of case reports, a lot of case series describing how combinations of antifungal drugs are useful and how the patients were cured and so on. But there are very, very few good quality randomized studies using antifungal treatment in very well-defined invasive fungal infections. Everybody who has read some articles when they made the registration of new drugs saw that a lot of the patients who were included in the study only had a possible or probable fungal infections, and a lesser percent had definitive fungal infections. So the combination therapy, all of you who are working as a clinicians know, when the patient is dying, we will give him everything. So this is usually a last attempt to save the patient. And so we really don't know if we are doing anything with the combination. There was one quite large study comparing voriconazole monotherapy versus combination therapy, voriconazole and anidolafudin. There you see there is a bigger percentage of patients died on monotherapy, but the difference was statistically not significant. And the conclusion of the study was, guess what? We need more studies. So about mucormycosis, there are no very good clinical data that could demonstrate a benefit of antifungal combination, but we know mucormycosis is even more severe disease than aspergillus, and very difficult to perform clinical studies. We have maybe 1 to 3 cases of mucormycosis in whole of the university center in 1 year. It's about 100,000 admissions, so we rarely see this pathogen, luckily, because sometimes it ends bad for the patient. So if you really do have to use a combination, then you should look what are you using. You should look drugs that don't have the same mechanism of action. And the final problem, which maybe are there any hematologists here? No? Okay. The problem with hematologists is whether we should start empirically or preemptively. Do we wait and observe the patient and see that the markers are going up, that there is a new infiltrate, that the patient is neutropenic more than 7 days, and so, or after 2 or 3 days of fever, the patient gets the largest possible combination of antifungal treatment. So the preemptive, when you are attending the sessions of various congresses where they talk about empiric versus preemptive, there is never a good conclusion, never. So you use what you use, and usually now the empiric treatment is maybe more simple, because you don't need to do serial galactomannan serial CT scans. It's very difficult to get CT scan every 2 days for a patient. In our hospital, it's like that. So that is the conclusion of my presentation. I think I showed you more problems than solutions, but this is something that we see in fungal infections.
Thank you. I will introduce the next speaker, Bojana Bejovic, coming from Ljubljana Infections.
They've seen me.
They've seen you, okay. Chemoprophylaxis of urinary tract infections. The floor is yours, Bojana.
We will speak, as I know, in the next 2 hours about other options how to prevent infections like chemoprophylaxis. And one of these topics is the prophylaxis of urinary tract infection, antibiotic prophylaxis of urinary tract infection. Oh, sorry. So I will speak about the prevention of symptomatic UTIs and not about the treatment of asymptomatic bacteriuria. You heard about it yesterday. It was a talk by Matea Logar, you remember? And I will also not talk about surgical prophylaxis in urology. It was also partly covered yesterday when Matea spoke about the treatment of asymptomatic bacteriuria before the procedures, including, of course, the urinary tract surgery, because in this situation we would like to lower the bacterial load and decrease the risk of infection. So the prevention of symptomatic UTIs. Classification, we also spoke about it yesterday. In acute, in uncomplicated UTI, non-pregnant premenopausal women with no relevant anatomic functional abnormality. Complicated, by definition, in a patient with an increased chance of a complicated course. And then we have all kind of like men in principle, then pregnant women, then anatomical, functional abnormalities, metabolic diseases, everything that increases the risk for a complicated course. Then we speak about recurrent UTIs. By definition, this is the recurrence at least 3 UTIs per year or 2 UTIs in the last 6 months. And then urinary tract UTI associated with the catheter in patients who have the catheter in place, or they had the catheter in place in previous 48 hours, similar to this generic definition of hospital-acquired infections and so on. And then we have the urosepsis. Many of my slides come from the guidelines that are available online and regularly updated by the European Association of Urology. And you know this document? You know this webpage? It is very useful for 2 reasons. You have really comprehensive guidelines that are regularly updated. And the other reason that is also useful in your practice is that these are urology guidelines. So you may speak with the urologist in your hospital and say, look, this is what urologists in Europe say. So that's the reason you have to follow this. Sometimes there is a miscommunication between an ID or clinical microbiologist and a urologist, and these are by origin the urological guidelines, so it's helpful by my experience. Again, the same thing, cystitis, pyelonephritis, recurrent, it might be uncomplicated. Then catheter is already complicated per se, UTIs in men are complicated, and then we can have actually urosepsis if we have an uncomplicated UTI and with a complicated, but of course the risk of urosepsis here is lower than if it's complicated from the start. A little bit of epidemiology of UTIs in women. If we start with this prophylaxis in women who have recurrent urinary tract infections, you see that this is 0.7 or almost, we may say, 1 episode per person year in a study of college women that started a new contraceptive method. But it was a subpopulation of young women, sexually very active, so it's really a common disease. And it is 10 times less often in population of postmenopausal women. And what is the topic of my talk today is this recurrence. And in young, healthy women with cystitis, the infection recurs in 25% of women who had in the first 6 months after the first UTI. So this is what we are speaking about in the first part of my talk. So it's really, if you see that it's so often, and then also the recurrences are really a burden in the population, then of course we also have this acute uncomplicated. What is typical is this the ratio 1 case of pyelonephritis per 28 cases of cystitis, which is much less common. And again, the peak annual incidence is in this young age of adult women. So this is just a bit of epidemiology to put it in the perspective. As you know, we have various non-antibiotic strategies to prevent UTIs in non-pregnant young women. And I will not go into the details of all this because the topic is antibiotic prophylaxis, but nevertheless, just a few words. Of course, sexual abstinence, this is something very clever to say to a young woman. Then voiding after intercourse, no spermicide creams. Perhaps this is the most important. Urine voiding after intercourse has not been shown to be really so much effective in the studies. Then behavior modification, all kind of perhaps effective Then cranberries. Cranberries looked promising in smaller studies, but then afterwards it has been shown, unfortunately, that it is not so an effective method. Perhaps better so D-mannose. Then vaginal probiotics, again, not really promising. Then also endovesical installation of hyaluronic acid and chondroitin, also borderline. A little bit better immunoactive prophylaxis, such as topical vaccination in a way, and then the topical estrogens also, I will show you later with another group of patients, they do have some effect. Starting with the antibiotic. First thing, it is indicated antibiotic prophylaxis in women who tried the non-antimicrobial strategies, but they were not effective. And then on the other hand side, the women who would like to go for antibiotic prophylaxis. It is still a discussion. Are these UTIs really so frequent then that a woman needs a prophylaxis or not? It depends somewhat upon the attitude of the patient as well. Of course, it is effective. It is effective. It reduces the incidence of recurrences. And this is a definition of recurrence that is per se an indication for the introduction of antibiotic prophylaxis. 3 or more in a year, or 2 or more in half a year. And at least one of which was confirmed by urine culture, because you see some women come with such such problems that might have some other origin, or a vaginitis, or trichomonas, candidiasis, and also some problems might have, or an STD might have different origins. So it should be a confirmed urinary tract infection. It's not enough. But of course, here is this. First, a trial of with the non-antimicrobial, then the discussion with the patient, and then, of course, the decision based on urine culture and the frequency of recurrences. What are the options that you can find in different sources? The first thing that is not actually prophylaxis, but is always mentioned with the prophylaxis, is the self-diagnosis and self-assessment. And this self-assessment, self-diagnosis is quite reliable. Most women know what is a UTI, and so it has been estimated that it's reliable in 86 to even 95%. So we need motivated patients who comply to the regimen. So not every woman can do this. This is also very important, this discussion with the patient. And you need a periodical control of the urine culture, because of course the bacteria might change. So this is one option that is not really a prophylaxis. Virtually one of the only diagnoses where we say, okay, a patient can prescribe or can administer antibiotics to herself after her own assessment of the situation. So usually we discourage it as much as possible. Then the postcoital one-dose prophylaxis, if UTI is related to the sexual intercourse, so this is the history, and then continuous prophylaxis, usually 6 months, but 1/2 have recurrences after 6 months, so usually we have to prolong it. What are the criteria for the choice of antibiotic? This is, so to say, the stewardship aspect. Identification and susceptibility pattern of the organism causing UTI. Yesterday we spoke with the most severely ill patients and the moving target. You can never tell what is the susceptibility profile of a bacterium that causes sepsis. But even here, we have E. coli that is only like 70% susceptible to trimoxazole, 80% to quinolones, and so on. So the situation is not easy anymore, I believe, in no country you come from. Then the drug allergy, and then of course these ecological collateral effects, including bacterial, mostly the selection of resistant bacteria. What else are the considerations? ecological collateral effect means that fluoroquinolones and cephalosporins are not recommended routinely except in specific clinical situation. Then the resistance to cotrimoxazole, trimethoprim alone, if it's available in your country, or cotrimoxazole, increases doubts of their use as effective prophylactic agent. Easy agents to use, safe, tolerability is much higher than, for instance, for fluoroquinolones, but of course. But you need a test. Then we have two warnings. One is more French, more limited to some countries, but actually it's true that long-term prophylaxis with nitrofurantoin might be dangerous because of serious adverse events in terms of pulmonary fibrosis or hepatitis or hemolytic anemias, and there are some more. So there are warnings now in the literature, and then is this general warning that was published by European Medicines Agency couple of months, half a year ago, about the use of fluoroquinolones that should only be used when other options are not available. This is quite, both warnings are quite a limitation for the use of antibiotics in prophylaxis. So here we may go back and say, perhaps let's try some other behavioral changes and discuss with the patient and so on. Antibiotic choices. One is the postcoital 1 dose. These are the dosages. You can use a cephalosporin, which one? In some countries we used to have cefalexin. Now we have cefadroxil. It depends. 1 dose. This is easy. And then continuous prophylaxis. This is the usual dosing of this prophylaxis. Then the post-menopausal women, this is another setting. Here the reasons are different. The incidence is much lower, but still not, it is there, the UTIs are common. What are the reasons for repetitive urinary tract infections? There is estrogenized environment in premenopausal women enables the growth of urogenital flora, lactobacilli, that are actually protective. Then there are other atrophy-related changes because of the hormonal decrease, and of course it is a kind of a local immunodeficiency, and also anatomically there might be changes, and there is some residual urine in the bladder, and of course. And what about the epidemiology? How big is the problem? They looked at the community dwelling women in their 80s in Scandinavia, and nearly 1/3 were diagnosed with an UTI in the past year, and nearly 60% had the UTI in the past year. So it's not like in young women every year, but still it's a burden, and it is already by definition a complicated infection. That means increased risk of complications. What are the pharmacological agents? Of course, vaginal estrogens have been shown to be more effective than placebo. Antibiotics are again more effective than vaginal estrogens, are even better, but of course more adverse events. Oral estrogens are not effective, and there is a study on oral lactobacilli that might be equally effective than cotrimoxazole, but less is known about it. But vaginal estrogens, and of course, if it may be helpful, and if they are not, then we have still this option with antibiotics. So with the choice, of course, you look at the isolate. Then we have a group of patients with risk for complicated urinary tract infection because of urological and neurological abnormalities. And one of the most common things we meet in our daily practice are the catheters. And as you know, this is a dangerous, urinary catheter is a dangerous procedure, dangerous device actually. Approximately 1/5 of hospital-acquired bacteremia arise from the urinary tract, and the mortality associated with this condition is quite high in hospitalized patients. And the incidence of bacteriuria associated with indwelling catheterization is 3 to 8 per day. So you can calculate the risk after a month. It is 100% plus. So it is, the catheter is, urine is positive. There is more 1 to 6 and more bacteria in the urine even before the end of the first month of a catheterization. So it looks appealing. It looks that we need antibiotic prophylaxis to prevent then these bacteremias, but unfortunately it does not work. So as you know, this is quite well known. So there are older studies, of course, and there is a strong recommendation in the latest European Association of Urology recommendations. Do not use prophylactic antimicrobials to prevent catheter-associated UTI. So if you deal with this patient in practice, okay, you will have different type of bacteria, different susceptibility pattern. It can be shown very quickly in a patient. The duration of catheterization should be minimal, and there is no help with topical antiseptics, antimicrobials to catheter, urethra, meatus. So actually keep it as short as possible. Then we have this is for long-term catheters. For short-term catheters, the situation is somewhat different. As you've seen before, the positivity of urine in patients who are catheterized increases with time, and if it's short-term, 14 days or less, we might do something to prevent this to happen. And the Cochrane systematic review in 2013 showed limited evidence that receiving antibiotics reduces the rate of bacteriuria and the signs of infection. So there might be a slight benefit. But in the whole context, still European Association for Urology in 2018 decided that this is not an indication for antibiotic. Perhaps we will have better studies that will show this or that. But at the moment, this evidence in comparison with the damage that can be done by antibiotics to the individual patient, and also more widely led to the decision that it is not recommended. Then there is one third situation, the situation when we remove the catheter. And if you remember your patients, you work in hospital, it can provoke symptomatic urinary tract infection. You have the catheter in place, you have bacteriuria, of course, and this is a procedure actually that can lead to a symptomatic UTI. And there was a meta-analysis that showed overall benefit for the use of prophylaxis and for reduction of infective complications. However, then they looked at the individual trials, and these results were non-consistent. So again, a gray zone. And then there was a subsequent, later on they did randomized control studies that did not show any benefit. So probably, because of all this, the recommendation is against the prophylaxis of UTI for the urinary tract catheter removal. If you remember yesterday, Matea showed a slide on, or there was a line on the slide, how to treat if this happens. Usually this is a lower UTI with some dysuria, and it can be treated with this really short treatment, 3 days of antibiotics. Can't be true. I'm so sorry. Then we have some other situations where we could speak about prophylaxis. The renal transplant patient usually get cotrimoxazole as many other transplant patients to prevent various diseases such as pneumocystis, toxoplasma, listeria, and also UTIs, especially but in general, and in the past there were recommendations, or at least the opinions, that if we find asymptomatic bacteriuria in a transplant patient, we need to treat it, and also ideas that such patients should receive long-term prophylaxis of UTIs. That is not true anymore. No, the usual prophylaxis, okay, also for other reasons, but not afterwards. And then this is spinal cord injury with neurogenous urinary bladder, no catheterization. Here again, there is antibiotic prophylaxis does not decrease the episodes of the symptomatic UTI. For the conclusion, antimicrobial prophylaxis is indicated in a subset of adult and also postmenopausal women when other options are exhausted. Unconvincing effect on short term, still not indicated in these special situations. Long-term catheters, spinal cord injury, renal tics. Of course, selection of resistance pathogens and adverse events should influence the decision. So it should be a careful decision by an expert. Thank you very much.
And I'm very pleased to introduce Tatiana Mrvic, who is also a member of the National Infection Control and Prevention Committee of Slovenia.
Hello, thank you very much for the invitation. I had a difficult task to do, to talk about decolonization and other pharmacological measures. I could talk about that for the whole day. I will try to do the resume of that quickly. And I know that you come from different countries, so you have different problems and you have different approaches. So we will probably discuss this during that lecture. How do you deal with that? What to do? Sorry. Oh, okay. So what we will do, we will talk mainly about decolonization. What can we do? What should we do? To whom we should do it? And on what way should we do that? And other pharmacological measures will be at the end. Just briefly, we'll go through passive protection and also vaccination, which is available for preventing the epidemical hospital-acquired infections. Oops. So, as you know, hospital-acquired infections are a big problem in our world. But in last decades, change focused from infection control to infection prevention. So we have to do the prevention with appropriate antibiotic use, and we have to do the proper infection prevention practices. And decolonization and also other pharmacological measures can do the trick there. But we also know that we can abandon only about a third of all the preventable targets. So we have two different approaches. We have vertical approach and horizontal approach. I don't know what do you use in your countries, perhaps you can tell me, but mostly we combine measures. So in vertical approach, we substantially reduce just one pathogen and a pathogen specific. So we have to do active surveillance for MDRs. We have to do contact precautions. We have decolonization available, mainly triggered for MRSA. In horizontal approach, it is usually done in countries which are endemic for MDRs. We are doing substantially reducing all infections. It is not pathogenic specific. We are using standard precautions, bundles of care, chlorhexidine bathing, especially in ICUs, and we have selective digestive tract decontamination, oropharyngeal and digestive tract decontamination available. So can you tell me what approach is better for you? What are you using in your countries? Combination of both? Combination of both, probably, yes. So we know also that colonization with certain bacteria can cause infections, can increase the risk of infections. So we have risk populations, mostly ICU patients, immunosuppressed patients, surgical patients, and patients who will be exposed or are exposed to invasive procedures. But we have also problems with patients. We are dealing with patients who are not at risk of getting infections. But in our country, which is not endemic for MDRs, we have problems with stigma. I don't know what it is possible in your countries, but in our country there is a lot of stigma for patients who are accidentally found that they are colonized or infected with MDRs, especially old people who are not admitted to the nursing homes, children who can go to the kindergarten, or, I don't know, grandparents who does have to have visits from their grandparents anymore because their parents don't want that the children contract the infection. So we have to have in mind also this population and have to do something also with them. What is the role of decolonization? The role is preventing an era of increasing antibiotic resistance to prevent hospital-acquired infection. It can be potentially useful prevention strategy against endogenous and exogenous infections, and it can cause benefits for all the patients who are colonized and also the surrounding patients in the hospital. Definitions. There are basic definitions. There is a common decolonization, reducing or eliminating the bacterial load in the body, and for the selective oropharyngeal decontamination and selective digestive decontamination. These are interventions to decrease colonization, mostly with pathogenic gram-negative organisms, also with MRSA or vancomycin-resistant enterococci or Candida in critical ill patients, in oropharyngeal, and in digestive tract, usually aimed to prevent bacteremia and ventilator-associated pneumonia. So this is quite busy slide. I won't bother with that so much, but I want to show you that there is quite a few evidence about different agents which are available for decolonizations. You have to see that there are different study designs made and different modes of decolonization. You see like universal, targeted, caused for the pathogenic organisms. Mostly it is meant for MRSA, something also for Staph aureus, which is susceptible to methicillin, and only few studies are done for SDD and SOD. Results are conflicting sometimes, and some of the preparates for these agents are doing well, and others are doing so well. So I already spoke about universal and targeted decolonizations. There are differences. In universal decolonization, you decolonize all high-risk patients, regardless of colonization status. Usually it is done in ICUs, and you don't need any microbiology or something like that just to do it for all the patients the same. In targeted decolonization, it is important that you collect screening swabs. So it is more time demanding. Then you have to do laboratory testings. It is usually done only for S. aureus, and you use antimicrobial agents only in patients who need them. So in one time you can prevent antimicrobial resistance. But there is a catch. If the burden, the load of the bacteria is low, sometimes screening swabs are negative, and you don't treat that patients, you don't decolonize these patients. So you have also problems if the patients are colonized with other bacteria, which can be a problem in ICUs or in surgical patients, like patients going under cardiovascular or orthopedic procedures. So about S. aureus, you know that this is a bacteria which is very common. About 50% of healthy adults have this bacteria. So if you just do the nose swabbing, you will miss about 20% of the colonized people. And the highest colonization rates are in patients with diabetes type 1, hemodialysis patients, patients with dermatologic conditions, patients with AIDS, and those patients who use intravenous drugs. What is also known that persistent carriers are only 20% of them. About 30% are intermittent carriers, and what is also known that persistent carriers have higher loads and higher risk of acquiring S. aureus infections. So nasal carriers, who also perianal carriers, have higher loads and disperse more SRLs in the surroundings. So the risk of infection is mostly in patients who are in ICUs, in hemodialysis centers, surgical patients, and also in long-term care settings. What about MRSA? Colonization rates are different in different countries. Epidemiological data are different. These are quite old data about the colonization sites in different body sites. As you see here, about 40% they have on hands, about 40% in inguinal region, 25% axillary region, so quite different. The epidemiology of Staphylococcus aureus infections is changing. Probably you know that in the last 20, 30 years, things changed a lot. The number of patients with infections increases every year. And we have this data, this is quite old data from California, from the beginning of this century. As you see that in the last few years they had quite a big up of infections with Staph aureus, but not hospital-acquired Staph aureus, but Staph aureus which is resistant to methicillin and is spread in the community, like community-acquired MRSA, which is a problem in America and USA, also in other countries. During the last few years, we had a lot of new cases of this bacteria, and it is most prevalent MRSA bacteria now in the developed world, I think also in Europe. So about screening mode, what should we do? In some countries, only the nose is swabbed. I don't know, in your countries, do you have one screening site only, or you combine? Three, okay. So this study done from the Switzerland showed us that if you do only the nose swabbing, 37.1% of persons were found to be nasal carriers, and almost 13% were solely throat carriers. So it is important to do also the throat swabbing. And also this study shows us that combining different anatopic sites yield the results. It is better to have more combined. So if you, for example, you have nares only swabbed, then you have about 27% missing cases. If you combine nares and axilla, you have about 17% missing cases. And if you combine nares and rectum, you have about 9% of missing cases. So it is the yield of the swabbing is better if you combine different sites. So what can we do about eradication? Mostly of MRSA, but also for Staphylococcus aureus sensitive to methicillin. You can do systemic antimicrobials for treatment of infection. Then you have topical intranasal mupirocin, butting with chlorhexidine mount rinse, and you have combination therapy with local and systemic approach. What are the facts about all these? The facts about local eradication or short-term eradication with local decolonization measures are generally successful, but most patients become recolonized later with the same strain. Most regimens seem to last up to 90 days, about 3 months. Therefore, decolonization is the better term than eradication. Recolonization rates in 1 year approach 50% in healthy healthcare workers and 70% with patients on peritoneal dialysis. Recolonization rate at 4 months in patients on hemodialysis was 56% and 71% in patients who were HIV positive. So this is not so good, huh? Yeah. So we can do targeted decolonization for patients who will be beneficial of that more, who will benefit for that reason more. We have two possible strategies for non-surgical and surgical. For non-surgical, we decide to do in patients who are on hemodialysis, who had recurrent infections of skin and soft tissue, like boils or something like that. patients who are subjected to immunosuppression therapy, and sometimes also for healthcare workers. What is the policy in your countries? Do you decolonize all healthcare workers? Do you take swabs in them or not? No. It's because if you do all other measures like hand hygiene, PPE use, and do it properly, you don't need that. But sometimes, accidentally, you get a patient who is accidentally also a healthcare worker and had MDR, had probably MRSA infection. So it is prudent for them to ask where they work. If they work in surgical ward, if they work in high-risk patients, with high-risk patients like ICUs or newborns, sometimes it is advisable to try to decolonize them. And for surgical patients, we do the decolonization in cases with high-risk procedures like orthopedic, cardiac, neurosurgical procedures, because it is known that mupirocin is perioperative intranasal mupirocin decreases surgical site infections in these patients, and it also is, this study is from 2006, intranasal mupirocin significantly reduced staph aureus surgical site infections in cardiac surgery. So about the preparation, the agent, mupirocin is most widely used. You know, you probably all use mupirocin. It has excellent activity against staphylococci, and it significantly reduces SRS infections comparing to no treatment, placebo, or alternative treatment. Side effects are very uncommon, but we have problems. We have also problems with this local topical antibiotic because success of MRSA decolonization at first week is very good, but only 60% after longer follow-up time. And it not prevents new colonization, or it doesn't increase in infection with CA MRSA carriers. And what is the biggest problem? Resistance. Resistance can occur with point mutation or acquisition of plasmid. Another agent, which is widely used sometimes in staph aureus, methicillin susceptible decolonization, is bacitracin. But you should know that this agent is inferior to mupirocin, and the rates of allergic dermatitis is higher compared to mupirocin. Retapamulin is a new agent. It is registered also in Europe, not only in USA. It is highly active against MRSA and mupirocin-resistant staphylococci. Nasal decolonization with retapamulin showed that almost 94% of patients were decolonized, and this duration of decolonization was quite long, but it is not approved for decolonization, for putting it in the nose. It is approved only for treatment of impetigo, so you have to be aware of that. So adverse events are quite common: sneezing, nosebleed, and headache. Povidone, it is old medication. It is good to, it is able to eliminate most of MDRs, but addition of vasosecretion, if you have runny nose or something like that, it reduces the activity of this compound. No good studies are available to support the nasal decolonization, and it has a lot of side effects of irritation and toxic reactions. Alcohol-based antiseptics are promising. In 2014, there was a study conducted about the use of alcohol-based antiseptic with benzalkonium chloride and oil emollients for decolonization of healthcare workers. So it was quite good results. So I think this will be something to look after in next year. Then we have also topical agents for the skin, for the decolonization of skin. Mostly used chlorhexidine gluconate, which has excellent safety record and diverse indication, like everything you can do almost with that. In settings of endemicity or horizontal approaches that include universal decolonization with chlorhexidine embedding, are more effective than vertical strategies, you know that. And there are also some things that are not so good. Skin irritation, especially in patients who have dry skin or some skin problems. It is ototoxic. It is toxic for cartilage, so they can be used. It can be used in orthopedic surgery. And what is most important, that it is not suitable for newborns and pregnant women because of systemic absorption. Povidone, it is also sometimes used, but not so good drug. And triclosan, which was used years ago, it is now not on the list of preparation for the decolonization because resistance, and they show that there are no beneficial effects over non-antimicrobial soaps, and there are quite a few safety issues about use of triclosan. What about octenidyl dihydrochloride? Do you know that preparation? Mostly if you work in Germany, I think you do know that. It is quite good because there is no resistance reported since 2007. On chlorhexidine, we have resistance reported, and on octenidyl dihydrochloride, we don't have it. It is safe because it is not absorbed through skin, mucous membranes, wounds, and it doesn't pass the placenta barrier. So it is safe to use in neonates, premature infants, and pregnant women. There is also oral care with chlorhexidine, only good data for that preparation. And what about systemic antibiotics? When to use them? Not routinely, of course, but it can be helpful in patients who are colonized in multiple sites and who have extranasal sites colonization, especially gastrointestinal tract, because with local compounds you can get through to the intestine. And also it is sometimes used, also in our department, for patients who are MRSA colonized in throat and are not able to perform local decolonization alone. So these are like small children, elderly people who had dementia and can't do gargling. You have to be aware that if you use only systemic antibiotic without local decolonization treatments, you are unable to attain adequate concentration in secretions, especially in the nose. If you have Staph aureus inside that, it is still unclear what are optimal dosage, duration, and if you can use mono or combination therapy. So I didn't put any slide about systemic antibiotics, but I can tell you that there are different approaches. You can use doxycycline, you can use trimethoprim, you can use vancomycin, you can also use with combination with rifampin, but you have to be aware of resistance if you use these drugs, and you have to be aware for risk of side effects, especially of rifampin. I don't know if you know, but especially in elderly people who have a long list of chronic therapy, there is quite a problem because there are interactions with rifampin, so it is prudent to ask clinical pharmacists, if you have one, if the drugs are compatible with that, so if you can use it. And also in young women, you can have a problem because if they are oral contraceptives, the contraceptive doesn't work so great if you give them rifampin. So what about SOD and SDD? What is the formula here? We use non-absorbable antibiotics, usually tobramycin, polymyxin, colistin, amphotericin, gentamicin, sometimes also vancomycin, 4 times a day. And in SDD, we add that also the short course of parenteral cefotaxime for 4 days. You use like a paste to do it in the mouth, and you can use like suspension, you put it down the gastric tube. The concept of SOD and SDD is quite long in use. Since 1980s, it is used in different facilities. It is usually used to treat or prevent nosocomial infections, especially pneumonia and bacteremia, and selectively eliminates aerobic gram-potentially pathogenic microorganisms and candida. So aerobic bacteria are the target, not anaerobic. You should put anaerobic bacteria, anaerobic flora, which is which is like important for your for prevention of other infections in place. This is this example of how can you use that. It is there are the different dosages of cefotaxime according to the age of the patients, and when you're targeting only aerobic gram-negative flora, you use polymyxin with obramycin. If you're targeting MRSA, you add vancomycin. If you're targeting yeast, you add amphotericin B or nystatin. So about the use of SOD and SDD in different environments. We have usually good data for environments with non-endemic MDR, and we have just few data about the use of these methods in environments where there is endemic MDR problems. Mostly of the studies were done in Europe, and these are these studies in Netherlands, Germany, France. They use different models, different approaches, and the final conclusions are that in ICUs with low levels of antibiotic resistance, the effectiveness of SDD and SOD was not modified by type of ICU admission. So it's not the matter if it is surgical or medical ICU. SDD and SOD improved hospital and ICU survival compared to standard care, and that SDD is more effective than SOD. These are the data about the use of SOD and SDD in surroundings with resistant bacteria. Problem is that these are study design are not so good, observational studies, retrospective, the number of patients is very low, so the results are conflicting. So in conclusions, they don't recommend the use of SOD and SDD in such environments, just to use it in settings with low level resistance to different antibiotics. What is also important is the application of SDD is more demanding, so you have to know that if you do that in your unit, you have to educate all the people who work there. But the treatment is cheap, and you can lower the use of systemic antibiotics that way. But it is very important that you close monitor microbiological results about the resistance which can occur during these procedures. So other measures about pharmacological measures to prevent infections in hospital. We know that we have endemic infections, we talked about yesterday, today, and we have epidemic infections, usually transmitted with droplets like influenza, RSV, pertussis, airborne infections, which can be quite a problem, and gastrointestinal infections. For all of these infections, you have to have standard infection-based infection prevention control. You have to do and have written SOPs for the prevention of all these infections. And sometimes you can do also prophylaxis. For surgical site infections, yesterday I think it was already mentioned about that, you have problems with infections in immunosuppressed patients, incidents in healthcare workers, especially Hep B and HIV. I can imagine also that you also know that also invasive meningococcal disease can be a problem in the case of breaching some of the recommended protections like using PPR. So in these cases, it can be also prophylaxis in place. But mostly we use prophylaxis for droplet respiratory infections and airborne infections if are introduced to hospitals and breaches of infection control are made. So what is the main points of effective prophylaxis? We have to have single pathogen, acute exposure, short duration exposure. We have to have suitable drugs available to do, and we have to have a little or very serious disease to prevent. But we have also possibilities of ineffective prophylaxis. It can cause overuse of antimicrobials. You can cause resistance to arise. There is economic waste because this can be quite expensive, and there is a lot of risk of side effects. Prophylaxis is aimed to prevent infection, but for clinicians is sometimes also preventing clinical manifestation. So if the patient gets infection, the infection would not be so serious. What are the measures? What are prophylaxis measures? Like we have disease-targeted, host-targeted, post-exposure surgical prophylaxis. In endemics, hospital-acquired infections, we usually use antibiotics, antifungals, antivirus. But we can also use vaccination in this matter. For example, influenza in winter for patients, or Hep B for healthcare workers. For epidemic healthcare-associated infections, the first measure is vaccination. Then we have also passive protection, antibiotics, and antivirus. So what it is available, these are most common epidemic, hospital-acquired infections that can be involved in our daily life. So for TB, we have post-exposure antibiotic prophylaxis, varicella pre-exposure vaccinations, or post-exposure vaccination or passive immune protection, the same for the measles. For rubella, important for pregnant healthcare workers, there is a post-exposure vaccination, post-exposure passive protection, because pregnant women can't get the active immunization because this vaccine is live. Then we have also influenza, pre-exposure vaccination, post-exposure antivirus, which are reserved only for high-risk population and in the case of outbreak. For pertussis, pre-exposure vaccination, post-exposure antibiotics in high-risk population or in outbreaks. And comparing advantages and disadvantages about vaccination and passive protection. Vaccination, fast application, cheap. Most of the vaccines are cheap. It is safe, and usually it takes long-lasting protection. But you have to be aware that after vaccination, protection is slow, about 14 days, months after the vaccination. And some vaccines are contraindicated in some group of persons, like pregnant women, immunosuppressed people, live vaccine. So passive protection has advantages that you have fast protection after you give that, protects individuals who are not responding to vaccination or have contraindications, who can't be immunized. It passes through placenta, so it protects also the fetus. Disadvantages, the list is quite long, expensive, human donors, so because human donors you can transmit infection by this time, usually time consuming because some of that passive protection should have been done parenterally. For clinicians, if you have a patient who gets passive protections, you have to postpone live vaccination for 5 weeks or 3 months because efficacy can be diminished. And if you have like clinical problems, you have to be aware that the serological testing for other diseases can be misleading, positive after that application. And immunity is not long-lasting, usually lasts less than 1 month. So we have a lot of different immunoglobulins on the market. Usually for the hospital we use non-specific immunoglobulins which are used for protection against measles. We have hyperimmunoglobulins for hepatitis B and varicella. So in conclusions, the majority of hospital-acquired infections may be preventable by evidence-based interventions. Decolonization prevents vertical and horizontal transmissions. The technique you will use depends on the type of patients, colonization site, and goals you want to achieve with that measure. We have also pharmacological prophylaxis with different antimicrobials, vaccination or immunoglobulin application, which can protect patients, individuals in whom hospital-acquired infections can arise and can prevent outbreaks in hospital environment. You have to be aware that the use of antiseptic agents can promote microbial resistance, and you have to be aware of possible side effects, not only allergic reactions, but also toxic reactions. And this is the case which demands prudent use of different pharmacological measures in everyday practice. Thank you.